Okay, good afternoon, everybody. Good morning. We will be starting our next session, which is the panel discussion. So may I invite the panelists first to the stage. Okay, let me just call out their names, okay, and introduce you to you all. Dr. Vaishnavi Jeyasingam, who is a consultant oncologist in Hospital Kuala Lumpur Ministry of Health, and she also is with Subang Jaya Medical Center. She will be representing Malaysia Oncology-City. Yep. Okay, and then our next person, Miss Ranjit Kaur. Miss Ranjit Kaur, Pritam Singh, she's a breast cancer survivor. She will be representing Together Against Cancer Association from Malaysia. And past president of Breast Cancer Welfare Association. And then let me invite Professor Dato Dr. Haji Rahim Abdullah, who is the Chief Executive Officer of the Malaysian Society for Quality in Health. And then let me also invite Professor Dr. Rosmawati Mohamed, who is a consultant hepatologist, and she's also the Master of the Academy of Medicine Malaysia. Okay. And I will also like to invite Dr. Suzanna binti Ahmad Bustama. She is the head of the Radiotherapy and Oncology Department, Hospital Kuala Lumpur, and she's also the Oncology Head of Services in Malaysia. Okay, right. Okay, let me also invite Dr. Anita Baghawi, who is the current president of College of Surgeons of Malaysia, not College of Surgeons, the Breast Chapter, College of Surgeons of Malaysia. Please. Okay, and then also like to invite, Dr. Izuna Mudla Muhammad Ghazali, who is our Public Health Physician and Deputy Director of the Malaysia Health Technology Assessment Section. Okay, so we actually have quite a number of people from the local side, and we would like to invite our, and of course this is the MCMC ASCO, our faculty members from the MCMC ASCO. We will have to convene on both sides of the tables here. Okay, and of course, the most important people in the room is actually our participants, right? So we will have to ask our participants to mobilize yourself and pull your chairs to this part of the room. See, that's why we use the cube. The cube is a very movable learning space we have in the University of Malaya. So please come move to the floor. Okay, and of course we have cameras, yeah? So please be aware that there are cameras so we don't block the cameras. Okay, actually the participants, you can also move the chairs to the other parts of the room if you want to. Are you all comfortable? Okay. So are we ready to start? Okay, we wait for Dato Rahim. So it's like the firing squad, isn't it? You have to sit there. Okay. All right. So maybe before we start, because we have a different group of people today, maybe Dr. Roselle, would you like to introduce the faculty members from the ASCO-MCMC CCAN group?
Yeah, good morning again, everyone. I'm Roselle de Guzman. I'm a medical oncologist in the Philippines and currently serving as chair of the ASCO Asia Pacific Regional Council and the course director for the MCMC CCAN. So I'll let the rest of the faculty to introduce themselves.
Good morning. I am Rolando Camacho. I'm an oncologist and I'm a global technical lead of City Cancer Challenge Foundation.
Hi, Eugene Ong. I'm a radiologist from Singapore.
I am Dr. Reema Pathak. I am a radiation oncologist working at the Tata Memorial Center, Mumbai.
Hello, everybody. My name is Jane Brock. I'm a pathologist from Boston, United States.
Hello, my name's Patsy Yates. I'm a nurse from Brisbane in Australia and I'm representing the International Society of Nurses in Cancer Care.
Good morning. I'm Pauline Carlton. I'm a medical oncologist from the Philippines as well, and I'm here to talk about palliative care.
Hi, all. My name is Kaur. I'm breast surgeon from Japan.
Okay, thank you very much for the introductions, and welcome again to the panel discussion that we're doing today. And what we are doing today is really to talk about MDT, championing MDT in our daily practice. So we will start some discussions first about what really is quality care. So I'd like to invite Dr. Vaishnavi, if you don't mind, to start off to tell us a little bit about what you think quality care for breast cancer is. What would be the definition?
So, morning to all. From a clinician's perspective, I think the main thing is we want accurate, timely diagnosis, investigations, of course, treatment, and support in terms of psychosocial aspects of the patient from the time of initial diagnosis and through the whole journey of cancer. So I think all of us are aware that it is not a one-off thing most of the time. Many patients, even with early cancers, do relapse. So the whole fundamental works with regards to the patient, the family, the support system, the extended family, whatnot. So I think if we talk about quality MDTs, is one which addresses all these aspects. I know in our setting, sometimes clinicians also tend to focus a lot on the report, the scan, when is the imaging, is it a PET scan, is it this? But I truly believe that when quantity is somehow maintained, quality will improve with that because you get to spend time. And I think a little bit of issues that we have on our side is because quantity and quality does not always go hand in hand. And many of us struggle with that problem of dealing with volume, and hence we feel that quality suffers in that process. Yeah.
Okay, thank you. I think we would want to hear from the patient's perspective, and therefore I think we have Ms. Ranjit here. Maybe you'd like to comment about what is quality care?
Compassionate healthcare providers and those who communicate with us using a language that we understand, not using medical jargon with us, giving us the time to reflect when we are seated together. It may just be a few seconds, and listening to us. That's the most important thing of how we are feeling about the whole thing, and recognizing certain psychological issues like anxiety and stuff like that, and be able to bring in other members of the team to help us through this. Because what the healthcare provider is thinking of is very different from what we are thinking of when we are diagnosed. So I think the two needs to meet in that way. And we need to be able to understand the disease before we can participate in shared decision making. Otherwise, I think things have improved a lot locally, but otherwise I think patients need to understand everything before they can participate. So that participation or engaging the patient in decision making still can be improved further. That's basically what I think we need.
Yes, so we can hear from the voice of the patient that, quality care is not just about getting the work done and giving treatment recommendations. It's actually really looking and treating the patient holistically. So let's look at the health systems per se. There are accreditations of hospitals, and this is basically on quality. We would like some comments actually from Professor Dato Rahim on this matter. What is quality defined by MSQH?
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning. Selamat pagi. Well, if you ask me, I've been in so many shoes and using so many hats, from being a provider as well as a patient as well. And of course, I've been with the Ministry of Health. I've been with the NGOs, MSQH and so forth. And different ways of looking at quality. But simply I would like, my thesis was about over 30 years ago, looking at quality itself. If I were to just rattle it, might take the whole day, right? It's just simply speaking, it's the patient-doctor relationship, simply speaking. What is the doctor's perspective? What is the patient's perspective? I think that is very important. But when you think about the health system of a country, for example, it's a big thing. Then we have this problem of what you call of trying to coordinate things, integrate the patient. Financial structure is there. We were just talking about the delivery structure, patient-doctor relationship. But then there's a financial structure that we are having in our country that is, to me, is fragmented. All right. Then the quality becomes a question of affordability. All right. And then there's the other part of the other groups of people which part of the health system with intermediaries. These intermediaries or middlemen or middle organization are actually supposed to facilitate and support the provision and delivery, or either or, the financial structure. When you look at that, you are an interim structure. I'm very impressed that you all exist. Before this, I didn't know you all exist.
Well, I think we have to.
I'm very impressed. Having an organization, all right, in this case, a society, trying to facilitate and support care and the patient-doctor relationship, all right? But our problems is that many of the intermediate structures are politicians and businessmen, and then where the conflicts comes in, all right? So the quality aspect of that facilitation and supporting. If I were to look at the health system as a whole, I would want equity, effectiveness, efficiency, responsiveness, which includes timeliness mentioned, but also in terms of responsiveness, in terms of respect and dignity. And of course, as a whole health system, risk protection from clinical risk or illness itself, all right? And of course, financial risks that many of our poor folks face. But in MSQH, we look at that aspect of clinical risk protection, where quality and safety of care becomes our main focus in MSQH. Right? Let's try to focus back on that. If I work in ministry and we actually had cancer on the top 5 list of burden of disease. That was in about 12 years ago. But whether resources are put into that is another matter. But last week I was in Institute Cancer Negara, right? National Cancer Institute in Putrajaya there, and I was looking at we have the Brunei Ministry of Health delegates there, looking at that. I was thinking about, this is something that's happening again. When I was working in nephrology in KL, all right, 40 years ago, everybody from all over Malaysia comes to KL to get that treatment, dialysis. All right. In oncology, this is the same thing happening again. Where are the resources coming from?
So you're mentioning about maybe, decentralizing care would be better in a way for better quality.
Yeah, I think the term is integrated care and care with integrity. All right? Yeah. But you're talking about the system, but the services goals are, I think, more important. Because I always tell my staff, because I've been at the front line and so forth, I always tell my staff, forget about what the politicians say, what we call the budget, but we can do something ourselves at the front line. Always think about the margin. Every single person that you provide quality care in any of those terms is one person more, right? If I have 5,000 staff and each of them do that a day in a year, I'll get hundreds of thousands of patients receiving quality care, right? I like to just extend that a bit. 25 years ago, we had health service goal, future health service goal, all right, that was put up as a goal for quality, wellness focus, person-centered, all right, informed person, all right, self-help, empowered person, all right, and that one is about having care close or at home, continuity and seamlessness of care, care that is customized or tailored to the individuals or the groups of individuals. Here you are trying to do it for the groups of individuals, and we hope in the future you can actually individualize it. That's what I think your attempt is in terms of multidisciplinary team.
Yes.
Right?
So thank you, Dato.
Yeah.
That was a good insight about how quality means really at the patient. It's actually the patient that we are trying to deliver the quality to. So maybe I can ask Dr. Rolando, because you have been working in all the different cities and you found that MDT is a major tool to improve quality. Could you comment on that?
Well, yes, multidisciplinary approach, more than the multidisciplinary team, because it's bigger, is a very important way to ensure quality, because in my opinion, it's the right of the patient to be advised on the treatment that the patient should decide to take, and the advice has to come from the best option that the professional has, which is the interaction between the other specialty. Many years ago, maybe one specialist was the only one to decide everything because the knowledge was small. Now it's impossible, and everyone has a role. So this is something that is important to recall, and has been contributing. In many countries, they have been trying to measure that. It's very difficult to measure what is really the impact of the multidisciplinary approach in the survival of the patient and in the quality of life. It's difficult, but there are many evidence that is true, that is impacting, especially in these two components, in the survival of the patient and in the quality of life.
Okay, so this is something that is being done in most of the cities, right? I think from the learnings, from the needs assessment that you have done in all the cities, the MDT as a tool for quality care is something.
Second, we have the experience of exploring this, because every city you will do that if finally the MOU between the Minister of Health and the CCAN is signed, that I hope will be too soon. I take the opportunity to mention that because we have been waiting for years. But in every city that is already 7 did that before, they do a very deep assessment of the capacity for cancer care in the city. Do it through a toolkit that is used for that. This instrument has covered all areas of cancer diagnosis and treatment and care. And one of the most important challenges that the professionals, more than 200 in every city, has been identified is the lack of multidisciplinary approach that they don't have in the city. And that's why a project similar like this one that you are implementing here through another channel has been one of the key projects in the city, developing multidisciplinary guidelines and developing, strengthening the multidisciplinary approach in the city.
Okay, thank you, Dr. Rolando. Maybe some comments about MDT and the oncologist. Dr. Rosel, what do you think? Is it something that is commonly used in the Southeast Asian region?
Yes, in different formats. So some would use it on an in-person basis, and during the pandemic, we see how we have transitioned into virtual meetings, and that included tumor boards or MDT. So on the perspective of an oncologist or a clinical oncologist or medical oncologist, we share this common barriers and challenges, time constraints, availability of the experts. But we always have to consider that these are factors that are related to commitment, teamwork, leadership, and efficiency. So those are the main components that we really have to make sure that all the members of the MDT are aware of. And all of these factors should really put into different perspectives. But what is common is we should always be striving for a patient-centered goal.
Thank you. Thank you very much. So I think we've heard from the oncologists, and I think we need to hear from the surgeons. So maybe Dr. Anita, would you be able to comment a little bit about how the surgeon, what is the surgeon's role in MDTs for breast cancer?
Okay. Good morning, everyone. From my experience, there is always a person who actually need to, not to say just lead and to start the ball rolling. So, for example, when because I'm working in Hospital Putrajaya, it's a Ministry of Health hospital. So, we are the clinician who first basically see the patient in the clinic, and we make decision whether patient needs to go for biopsy, and then send them for imaging. So sometime for certain cases, decision making is quite difficult. And in my center, we do surgeries and all that. And when we have complicated cases, then we will refer to the oncologist. But it's if it is just a one-to-one discussion, it can be very difficult. So it doesn't look, we don't feel like treating the patient as a whole. So we get a few of our experts, definitely the surgeons, radiologists, and the pathologists as well, the core team member, to be in a MDT, this sort of discussion to decide on complicated cases management. It's quite difficult to get all the cases to be discussed. I guess maybe lack of time, as you mentioned earlier, and to get everyone to be in that discussion. So I think this is a best platform to get the whole idea of MDT to be spread out to not just to the surgeon who manages the patients, but to the rest of the experts. And I think there are so many levels of MDTs actually, because I have worked in a hospital whereby we discuss on the biopsy results and what are the treatment plan for the patient. Do they go for a repeat biopsy? Do they go for for surgeries and so forth? So I think to get an ideal MDT as described in as everyone knows, I think it's quite challenging, but we are trying to do our best to get sort of like a consensus in terms of patient management. And definitely we, surgeon as one of the main player in the MDT team, but definitely we need our colleagues, radiologists, pathologists, of course the oncologist to be in the team. And I think in Malaysia, from my experience, we are lacking of when we discuss, we always get the clinician to come, but we missed our breast care nurses. I think they should come in the MDTs. Most of the time, we can't talk to the patient too long. We have many patients to see. So when we need to handle a person with a newly diagnosed breast cancer patient, I think breast care nurse is one of the most entity of in the whole team to manage the patient. And of course, palliative care physician, I wouldn't say it's new in Malaysia, but we don't have the numbers. And only at certain big centers that this group of clinicians are around. So to get everyone to be in the MDT, I would say rather challenging. Okay, but we definitely have the core team members in the MDTs.
Yeah, so I think it sounds like the initiator of the MDTs could be the surgeon.
The surgeon, yes, because we are the primary clinician, the first clinician to encounter with the patient.
So I think in the document we mentioned just now, there are a few roles that everybody plays within the team, and you mentioned there's this thing called the clinician leader, the MDT leader. So it looks like maybe, the surgeons may be actually the right person in some instance, in most instances, especially newly diagnosed breast cancer patients. And maybe this is one role that we have to advocate to our young surgeons in the College of Surgeons.
Yes, definitely. Thanks.
Okay, I think we will now, because we've heard about from many different people, different backgrounds. Now we want to talk a little bit about the document that we talked about this morning. And we'd like to invite the ASCO-C faculty members to maybe give some comments about the document that was circulated earlier to you all. Roselle, would you like to start first?
The local team has really did a great job on developing the document. Well, one thing on the perspective of a clinical oncologist or medical oncologist is, even in my own practice, we encounter patients who we don't have the tissue diagnosis yet, but they're presenting in unusual clinical presentations. And most of the time, these patients have exhausted all the workups, have done several imaging studies, but still they're not being referred to the oncology service. So perhaps that's one thing that the local team may consider, because you'll be saving a lot of time, resources, and the patient's overall outcome if those who are not yet diagnosed to have cancer, but they are presenting in unusual ways, that they should be also referred to the MDT. We have seen cases like that. I'm not sure how is it in the local situation, the local practice.
So it's those type of patients that stump the clinicians, right? The ones that we cannot come to a diagnosis, you mean?
No, they are being seen by other specialists, could be internists or family physicians, with a high suspicion for malignancy, but yet they haven't reached the right specialists or the right people. So those who are highly suspicious to have malignancy, they may be presenting in atypical manifestations. So not so many of them, but we have to consider that as well to be presented as part of
I think we always see this, isn't it? The patient who has been investigated extensively, but maybe by the wrong discipline, because you're so specialized nowadays that sometimes, by getting more input from different people, from different disciplines, you can actually come to a diagnosis. So do you mean that we should be adding to the diagnostic aspect of the MDT, like a little note?
And the awareness as well to the other, disseminating the information to the other practices as well and other colleagues, that MDT is existing if you have patients or seeing cases that you think that it's something that needs to be discussed during the MDT, then have it included in the agenda.
Okay, I think thank you for that comment. I think it's very important that we live and exist within our little scope of breast MDT teams, and then sometimes breast cancer can sometimes present with different ways, right? And if there really is some questions that they want to bring to an expert panel, so that's what you mean, right? They can actually access a referral to the MDT.
There are situations where patients would present with, like for example, CNS metastasis. They will present to the emergency room with headache, vomiting, increased intracranial pressure. And then the attending physician could be an internist or a neurologist. Don't even bother to do a breast examination, then only to find out that there's a huge mass there that the patient had been having for several years. These things are part of our commitment to our patients. So I'm not sure with the local experience, but
yeah, I mean we're open to any discussion. If anyone has any more input on this matter, anyone?
Yeah. I don't know whether it's clear. I read your paper that you sent, and I don't know. It's not that clear enough in terms of the main objective of that multidisciplinary team. What is the actual main focus? The experience that I got about 40 years ago in nephrology, where we had actually multidisciplinary team, is basically establishing a care plan for that patient, the individual care plan for that patient in the course of that illness. That's why you need a definitive diagnosis, accurate analysis and staging and so forth, and predictive analysis of that, and then coming up with the plan of management of that patient. It's not that clear in that MDT. I think that you need to have that clear. I think that is your main focus, isn't it? To have that
the treatment recommendation
customized to that individual patient.
Yeah. Yes.
So that
yes. Yeah. So the document will actually has what are the outputs from the MDT discussion. So those are the outputs, and then we also mentioned that we need to communicate that to patient, and we have to document who will communicate the treatment recommendation to the patient. So those will be written in the medical records.
Because our records are quite fragmented all over.
Yeah, I understand. It's always a problem. In Malaysia, some people, we have a lot of hybrid type of paper and EMR. So sometimes things go missing. So I think there was some comment from Rolando, isn't it?
Yeah. I think you are right. It's, the MDT is to evaluate the patient when the diagnostic is confirmed. So it's from confirmation of diagnostic to the end. But what is the problem with this? Is that we cannot separate things like that so easy, no? Because actually I tried, because our organization is promoting access to cancer care, so it's not in prevention or early detection or so. But the problem with cancer care is that if we don't have, if we still having patients in very advanced stage, what treatment can do? Not much. So it's anyone who works in cancer care, especially in those curable cancer, like breast, should promote early diagnosis. And I'm not talking about screening. Early detection has two components, which is screening for asymptomatic, but the other one, which is sometimes, I don't know why, especially when it's more needed, people don't want to talk about early diagnosis, which is opening facilities for patients to access. Because the problem is not to advise, you have to get the screening. That's very easy. It's very, I was said comfortable for the authorities to say, let's do the screening and then people don't go. So who is responsible? People, not the system. But in early diagnosis, you have to create awareness, but you have to create facilities for diagnosis and for treatment. And that's more difficult for the system. So sometimes, I don't think that they do it consciously, but sometimes it's what happened in most of the low and middle income countries that do not care about this part. And in the high income countries, that problem do not exist. Facilities are all over. So for early diagnosis. So it's important to advocate, not to focus in the early diagnosis, but to advocate for early diagnosis, to have more chance for when you treat the patients. But it's true. It's the decision after the diagnosis what is more recommendable for the patient to take.
If I may add as well, we also get patients who are in their metastatic setting or those who have recurrent disease, and MDT is a great area or an opportunity where the future plans, including palliative care and early intervention, advanced care planning, is a great opportunity where that should be discussed with the patient and the caregiver and the family.
So I think these are very important points. I think Rolando, you mentioned about early diagnosis, and what more, MDTs can be a tool to improve the quality of early diagnosis. In a sense that to get to do early diagnosis, you need all the components of making that diagnosis, right?
We in the MDT should concentrate to focus in planning the treatment for the patient in the state the patient has. This is the focus of the MDT. But of course, something is not to include, but to advocate. Because if you are in charge of planning the treatment for the patient and providing the treatment, maybe it will be distracted to focus in another topic, of course, of early diagnosis. But you should advocate for that. And it's a very nice place, the right place to show how early diagnosis is. Because when you do your statistic of what you have been seeing in your MDT, if you see all the patients, you will see what is the proportion of early stage and advanced stage and so on. So you can say, look what is ongoing. Somebody has to fix it up. Maybe it's not the MDT. I don't say it's a responsibility of the MDT, but the MDT can show what is the situation and how early diagnosis is not working when you keep on having advanced stage in diagnosis. Something is wrong.
Yes, I think Ranjit, you want to say something? I saw her hand raised first. Yes, Ranjit, go ahead.
I would like to add something about patients' point of view. Most patients, when they are face to face with the doctors, they generally tell us that I don't know if I can trust this doctor with the information given or with the diagnosis given. Maybe I should go and look for another doctor. Most of the time, they're looking for the best doctor in town. So that's when they start going doctor shopping and get confused in the end. So I think that message has not been given to the public that there is an MDT behind this that is discussing your case, and the result that the doctor is giving is coming from an MDT discussion. Because according to the patient's story, it's usually the doctor just looks at me, looks at, okay, you have got this stage and we're going to give you this treatment. And he said, how did the doctor decide so fast? So they have no idea about it. My second thing is that I think we need to increase the number of nurses in our country, because the nurses give the best support. Doctors are so busy, they don't have time. So if the nurse can take over, and they in my own experience 24 years ago, it was the nurse who gave me all the support. It was the nurse who was constantly coming back and forth to me, even when I was an inpatient. The third thing that I want to add is palliative care is a bad word to us. It's like just before the mortuary, the palliative care person comes to us. All right. Everybody is fearful of that word. And that's when they start saying, doctor, do you think there is another treatment, another medicine that you can give me? I don't want to go to palliative care. So I think palliative care has to be introduced right at the beginning, right upon diagnosis. Even if it is a palliative care nurse, let the nurse be with the patient. We don't need the palliative care physician because we don't have sufficient palliative care physicians to start with upon diagnosis. But I think they need to be there so that this bad word can be changed to something good. Because palliative care has a very important role to play right from the beginning itself. So that's what I would like to say about MDT.
Okay, thank you. I think really patients do not know that this process at the back of the decisions and the treatment recommendations that we give. So maybe some comments. Rima, you want to tell us more about the document, maybe?
Just before I comment on the document, I just wanted to bring it on the forum that whenever we keep a patient aside for MDT discussion, we usually inform them that since yours is a special case, we would like to discuss it among the team of doctors, come to a consensus among all of us. Several times we face situations where there isn't enough evidence published for you to fall back upon, and it's only the experience of local clinicians that's going to guide your decision. And this is what we inform upfront to the patient. It's always good to be honest to the patient that there isn't evidence, so you don't go Googling about it. You're not going to get anywhere. So that's what we do, so that the patient's aware that it's a collective decision, and I'm not going to get a different decision if I go to a medical oncologist versus a radiation oncologist. So that's point number one. The other point that I wanted to make was that it's not just the MDT at the time of diagnosis or at the time when you're deciding the care pathway. It's also every single time that the patient actually veers off the care pathway. So sometimes you've decided a curative intent treatment for a patient, but the chemotherapy hasn't worked and actually the patient has progressed. You're now going to change the diagnosis from curative intent to a palliative intent. At that point in time, when you're changing any part of the treatment that was pre-decided, the patient goes back into an MDT discussion. Because several times as a clinician, you may not be aware of other treatment options or any other clinical trials that are ongoing in the institute or may have recently received approval for, can be offered to that particular patient. So it's important that not just at the beginning, but also several times through the patient's care till the end, the patient may oscillate back and forth within the MDT. So it's not just at the beginning. And I do commend everyone who's behind the CPG document to have an exhaustive document but the only thing is that people should stick to it. Policymakers should see to it that there are certain, like yesterday again I said, there are certain service indicators that you emphasize upon. So you may have 15 indicators that you've put in the document, but if you're not going to implement them strictly, it's not going to work. Like in our country, if I just can give you an example, maternal mortality rate is an indicator that our ministry emphasizes upon so strictly that our gynecologists are actually, or obstetricians are quite afraid if they have a maternal mortality in their clinic or in their nursing home or hospital, because they have to fill a 15-page document. It goes to the ministry. Ministry actually communicates back to discuss that. Why did the patient die? So if the ministry is serious about something, they have to take feedback. And only then will this culture be implemented and will remain sustainable. That's what I would like to say.
Just one thing that, not to interfere, but because Rima mentioned that, and I totally agree. I think that in this session, the most important thing that I would like to see from this session is the commitment of how these leaders who represent everything has to deal with breast cancer here, are going to support or promote this multidisciplinary approach. I think that it will be very good exercise to see how they envision to the support that they can give from the perspective of everyone.
Yes, we will be going to that soon, Rolando. So I think there are some more faculty members that may want to comment on the document before we go to that section.
Yeah. When I was reading through that document, I was struck. You have the radiology pathology correlation part, and I think that needs to be separated from the the tumor, the tumor board type of multidisciplinary meeting. I think if you have a sufficient volume of cases, it's a different conversation when you've got your radiologists discussing with your pathologists, is this a good correlation and what are we going to do about it? And then and bringing in the surgeons. And that's not the same group of people who you want in your multidisciplinary tumor board meeting where you've got your rad-onc and your med-onc. They don't want to be there at that other meeting. It's a waste of their time. So I think, when you're coming up and you're planning that, there are two different meetings. And the other thing I wanted to say is that as a pathologist, we're the only people who do not see the patient ever. Right? So why we feel very divorced from the whole thing. And I think a great way to get your pathologist to come to your MDTs, because I realize that they don't want to show up, right? Because you can just read the pathology report. The way that you do it is you ask them, you empower them to teach you, right? So right from my very first day as a junior doctor, our job we were told our job at tumor boards was to educate those stupid physicians, educate those stupid oncologists and rad-oncs because they don't understand pathology. And so literally as a baby resident, I had to take photographs down the microscope of the cases and prepare a PowerPoint presentation and show them at the tumor board. So we literally showed the cases at the tumor board. We became a little more sophisticated. We wheeled in a microscope into the room and we then projected it on the screen. And now, thank goodness, we have Zoom. And so we just considered our desk with our the camera on our microscope. But those are the things that, it was ingrained in us that was our role at tumor board, because we weren't making the decisions as pathologists. We don't make that decision, but we're there to teach you. And that's kind of how you get your pathologist buy-in.
Oh, thank you, Jane. That was a very good suggestion. I think we might follow it. Okay, carry on.
Thank you. And I was really pleased to hear that we're really coming to understand the value that the nurse can bring to the multidisciplinary team, and it's the patient's voice actually that is really enabling that. And so thank you, Ranjit, for bringing that to the discussion today. One of the things, and I think your guidelines very clearly articulate that that's a really critical part, and that's so important. One of the things that, in terms of best practice that I've learnt though, in terms of teaching younger nurses around how to best optimise their contribution to the MDT, is that nurses still need a bit of education and support in terms of how to communicate that. So yesterday, Jane presented how the pathologists present like a synoptic report. In a sense, one of the things I try and teach nurses to do is to structure their thinking in terms of a comprehensive assessment of patient needs using, a very holistic assessment, and to think about the way in which they can bring that in a structured way to the conversation so that it's very clear what the patient's needs are, and that they're able to bring that so that people can hear that and it doesn't get lost in all of the rest of the important conversation that's got to happen at an MDT. And it's one of the things I learned as a young nurse is that I would bring things to the table, and oftentimes it would be, oh, that's really important, but then they'd go back to whatever else was the discussion. And so I think it's a skill that, I've learnt with experience, and I try and teach younger nurses is how to actually really communicate effectively with influence and with power. And also sometimes if the team hasn't heard, to very respectfully sort of come back to that in the conversation at an appropriate point. So I think it's really supporting our nurses to be empowered as part of that team.
That's a really good comment. Maybe you should have an appendix on psychosocial and patient-centered information that needs to be collected for the MDT. Yeah. Yep. Thank you. Maybe.
Well, I share Patsy's gratitude to Ms. Ranjit, because I think a lot of the points that I wanted to raise, she's already very eloquently raised up. So thank you very much. I think straight from the patient's mouth, right? On the importance of involving palliative care and that rock support for the patient. What I would like to add is what I mentioned yesterday as well, that each specialty is there to notice the things that other services might not be noticing. So in a hospital where Dr. Rosel and I used to work together, there was this very pleasant pain management doctor who was always there at every tumor board. And whatever the cases were going to be, she was very committed to be there every Wednesday. And she was a useful presence there because after the surgeons have presented, she would always ask, whether or not it was a stage 4 patient or not, she would ask, is there pain? Because even if there's a mass there, it's very rare that there won't be any sliver of pain. So she would always just remind, have you asked, have you investigated about the pain? And sometimes it's because you're thinking about your clearances and everything else about the case, but we forget to ask, what is the patient feeling? What is going on? What is hindering this patient from receiving the kind of care that she needs? A lot of times family issues come into play. We won't know that if we don't ask. We won't know that if we don't assess. So if it is not that feasible for a palliative care physician, as Ms. Ranjit mentioned, to be there, then we choose who do we appoint to notice these things that we often forget. Yeah.
This document is so nice and easy to understand. So I belong to Hyogo Cancer Center, so prefecture government center, and not big and not small, so middle class. So we have 3 types of MDT in my hospital. So I'd like to introduce 3 types of MDT. So number 1, pre-op MDT for every patient once a week, including surgeons, oncologists, radiation technologists, radiation oncologists, pathologists. And number 2, post-op MDT for every patient and recurrent breast cancer patient once a week. And at the last is nurse-oriented MDT, nurse-oriented. So we discussed for a patient needed special care, and it consists of breast care nurse, clinic nurses, and nurse who care inpatients, and nurses who contact local hospital and clinic, local clinic. So it's a good for nurses to study leadership. So I'd like to say leadership, a leader should not be a physician always. Thank you.
Betsy, do you want to comment? No, that's a very important point. And I think one of the things when we think about the nursing team is that sometimes it's very important for the nursing team themselves, whether it's the breast care nurse to talk to the chemotherapy nurse, to talk to the inpatient nurse, to really get that whole picture as well. So I think that's one point. But I think the point about the purpose of an MDT, it sometimes can be to bring those other complex issues, which may not just necessarily be an immediate clinical issue, but it may actually be a more complex psychosocial or supportive issue that needs to be addressed.
Yeah, I think that's a very nice sharing because it's a different perspective of MDTs, and as you say, the objective could be purely non-clinical, right? So I think we should take that into consideration when we review the document, whether we should be thinking about optional type of MDTs involving and to encourage the nurses to take on more leadership roles and to communicate among the different teams within the nursing fraternity. You know, I'm looking at Matron Aswana. Okay, so Rosel, you have some more comments.
Just to build on what have been said earlier, in our local practice, it's routine that for all patients presenting with breast masses and diagnosed, for example, or having the core biopsy or excision biopsy turn out to be breast carcinoma, medical oncologists or clinical oncologists are engaged early on before patients being subjected to definitive surgery. We see a lot of locally advanced diseases where it's very clear that neoadjuvant treatment is beneficial. It's very clear about the advantages of giving neoadjuvant treatment, whether that's systemic chemo, hormonal, anti-HER2 therapy. So it's very important that the clinical oncologists are engaged early on. You know, the benefit of MDT is bringing together all the specialists, all for the benefit of patients.
Okay, thank you, Rosal. Okay, thank you for all the comments. I think it's been really nice, very different perspectives, and I think it's definitely going to add value to the document after this, after all your inputs. Okay, let's now go to the next section, which I think Rolando is trying to get us to get on with it. It's about how we can really implement this program and how do we sustain it. So I've got here Professor Dr. Rosmawati from the Academy of Medicine. Whether, you know, what would be the role of clinical societies in ensuring that we practice MDT in the country?
Okay, I think if you don't mind, I don't think I will start on that note. I think I would like to share what we've done for HCC to see that maybe some of this can also be the way we think about the barriers. We think that it might be difficult to actually even initiate it in certain circumstances. So if you don't mind, I have slides and let me share. Right. And I try not to be too long.
Okay.
So I know we are HCC is a different disease altogether, and definitely it is different because it is more complex in the sense that it involves the intersection of the liver and 90% being cirrhotic, and also looking at the cancer itself. So we actually had this ongoing already in UMMC for, in fact, I put it at more than 15 years. It's about 20 years now. Okay, never mind. So you can see that, if I go back, let me just try to go back. We do not necessarily have to have everyone in from the beginning. And definitely, even from the start, I do not have an MDT coordinator. And also, I do not have palliative care, but we have a definite plan for those with BCLC stage D to be referred, expedited referral to the palliative care team. So these are part of the discussions that have been ongoing. And even pathologists are not featured, not because you're not important, but because for ACC, more than 90% of the diagnosis is made via imaging on the multiphasic CT or MRI. So we have got no doubt that the benefits of MDT for ACC at least is extremely beneficial. And we have many studies to show that it not only improves survival, which is the outcome which we are all hoping for from the patient perspective, but it did have many things in terms of early, not detection so much, but early realization that this can be given a curative potential. And also, if you look at it, there are decisions made that change from the initial ones that the primary team had decided from the beginning. Because we asked the primary team, what do you expect to have from the MDT? Ultimately, it is the management plan. So, of course, we use the ECHO platform for this. And basically, this physical type of MDT was started by getting everyone together over lunchtime, entice them by having lunch. In fact, I had to provide it from my research fund to get everyone to come together. And it's automatic because the MOs need to present. Our medical officers rotate by the master's program, and I think it's the same for the others, every 3 months. So we have a new team every 3 months. And if you do not do something to actually get them to have the same focus, it will not work, because you need to get them to have a good template. You need to know what is the outcome that you want to expect from the discussion. And I think I will show you later how we actually did it. So basically here, this is all about this concept, all aligned with the echo fidelity concept. So For us, we already decided that we're going to invite people for the UMMC, outside UMMC, to be able to actually connect to us and have a discussion. It's the concept of echo moving knowledge, because we don't want the patients to be referred to us. We will have the scans, we will discuss, and once a management plan is decided, then you can actually get the person to be seen in the clinic or when admitted to the ward. So we found out from the beginning that how do we actually make sure that a nationwide access is possible? So we found out that there are many other MDTs for ACC that's already ongoing, for example, in Selayang. But there was one unfortunate circumstance, because now, as you mentioned, our data did show that the late presentation is, of course, the main barrier, and that's why, in terms of death, it is the third commonest cause of death. And this is what we actually found, that, of course, there's no oncologist in Selayang. We do not have that. And they would always have to refer physically the patient to IKN to do that. So we talked to Dr. Suzanna, how can we help? So at the end of the day, we said that we do not have to have everyone coming together, but just one person scheduled for the weekly session. And that has already been started. That hopefully will be starting in the next 1 or 2 months, that we're going to have scheduled oncologists for the MDT in Selayang. And for UKM, for UKM, because I actually just joined there to actually run the clinic there, and I said, how come your MDT, you say, is for surgeons first, and then oncologists, and then physicians? I say, why are you not putting together? I think there was talk, but it never moved, but now it will move. So I think use whatever is already existing, strengthen what is already available, and see how else can be helped. Like if you don't have the specialty at that place, then you need to find out how, because all virtually now, how can it be done virtually? So I will also mention that an opportunity came for us to really look at it together, because everybody have to keep up to date. And the most important part about MDTs is actually really trying to see evidence-based approach to your treatment, right? So when this BCLC staging was actually published and published in April, we said, now we have to have a discussion with everyone. So we actually had a second kind of MDT, which I will show you later, but just before that. So this is the template we use. In fact, the template is very similar to what we had originally used before, but because of certain advances or update that was in the recent publication, we had to have some changes. And I just showing you as a one-page thing, because we have tried to put a one page, but there's a little bit more detail that I have added since then. I've also added the types of treatment that you should be considering, according to the latest guidelines. And also, for hepatitis B and hepatitis C, we want to know the treatment status, not just the liver disease status. So we do need to show them, or especially the MOs, that these are important information for us to guide treatment. So basically, this is the second echo session that we had on a regular basis. But we were not too ambitious, because this is new. We cannot have it weekly, and once a month was a struggle at the beginning, because I was only doing it together with Dr. Tan. But eventually everybody saw there was a need to have this, because in fact, hepatologists, or rather gastros with liver interests, are very few in this country, less than the fingers of your hands. So basically here we need to get everybody to work together, and we have this ongoing session now for more than a year. And this has been quite successful, because when the publication came, we actually had that session where we said we need to actually implement a newer approach that is recommended in the guidelines. The benefits of echo has been shown by many publications now, and it's really about replicating the best practices, like what you have actually shown in your document. So I actually should have shown it from the beginning. We actually signed the agreement in 2019, and very soon after was the first echo-style MDT was done. There's a slight difference between what echo fidelity and MDT is, because in every echo session, we usually start with didactic teaching for 10 to 15. We did start that from the beginning, But because there's so many cases, the pressure, so we need to have the teaching session separate. So that's why the monthly sessions was actually done. And I think Prof. Aishah has already told you the concept is really linking the specialist, which is the hub, with the spokes. And your spokes are not going to have their own MDT session. You're going to get linked to what is already existing. I think it can never be a smaller hospital to have their own MDT. It will not work. And I think it will not be sustainable even if you start it. So I think the principles of ECHO has been shown, not just using the platform via virtual. We use Zoom. It's a free Zoom session. So we will actually give, because we are the main signatory in UM, we actually have someone to give you, if you have gone for training, the login details. And basically all about this is the case-based discussion and some of the other publications showing that this is actually really a good element of dynamic teaching session. And in terms of CPD, it actually met all the requirements to replicate this for CPD best practices. And like you mentioned, this MDT doesn't stand alone. It must be part of a comprehensive plan. And what Rolando was saying, that ultimately everything about cancer is about early detection, isn't it? The Bruce survival. So if you look at what is necessary, I mean, this is lessons from our WHO hepatitis framework that I've used here. We do not have a CPG for ACC up to now. So we actually had to do something to actually see what are the needs. And we have data to show that currently our epidemiology of ACC is changing. So we need to actually really see how else can we strengthen data. I think I've gone too far, isn't it, just now? Yeah, okay, never mind. So if you look at what we actually also need to do is position how ACC in terms of the cancer response. It's not going to be like your breast cancer, which is the top cancer, definitely. No one will say that you cannot do, you are doing too much of breast cancer. You have to do more, in fact. But for liver cancer, we have to show somewhere that it has to be done. And we have to do this by integrating with NCDs. We actually have to show that this is part of the problem. Because if you look at the changing epidemiology based on our latest data, it's actually really going to overtake hepatitis B in the very near future, if it's not already is doing, based on this 2021 publication data. So that's the other thing about positional data. We have some data, but we don't have enough. But ultimately, we want to have a proper data collection with the National Cancer Registry. We need to talk to how we can do this better with NCR. And the best chance now is because of the introduction of the ICD-11 earlier this year. So we've had that discussion to show that whatever template we'll be using is going to be linked to that data collection as well. So this is in progress.
Okay.
And
yeah, you okay with time? Because,
this is the last one. Okay. So really about early detection, it's about optimizing the early detection of ACC risk factors. And this is where I said that you need to link with the NCD. And it all is about the CPG, because we use the recommendations from a type 2 diabetes CPG, which included fatty liver screening, to show that we can integrate with what is the bigger picture. Cardiovascular death is the commonest cause of death for fatty liver. So we need to do that better. And this is one of the efforts with MATAS, which they asked us to collaborate to actually train GPs or primary care providers to disseminate the content. So this is part of the effort. We've launched that with all the other 4 primary care providers, including the FMS Association, and these are the risk factors. So these are part of the program in the bigger picture.
Okay, thank you, Professor Rose. I think to learn from different diseases is always, is like the rapid way of learning, right? You learn from each other, different disease. We can learn from each other. Prof, so, in terms of the Academy of Medicine, I think we've had some minor discussions about how we're going to implement this in the long term. And I'm sure Academy is going to be very supportive of actually being the secretariat, isn't it, for this ECHO project that we hope to move on next year?
As I said, it's not sustainable. So what has happened is, you're right, professional societies actually have a good role to play here. So for my liver echo, they actually only saw it very recently, in fact, to show that this can be optimized. This is actually a training opportunity nationwide than your society. So MSGH has decided that they will take over my liver echo. I don't have to do this anymore. So similarly, for my ACC MDT, although I initiated, I even took the time to go through the case presentations initially just to make sure that people do follow SAMHSA. Now it's automatic. I don't even have to host it. It is automatically hosted by the team that's actually running it.
Yes.
So yes, societies should be discussed. There's another opportunity because now the training, as all you know, the parallel pathway has been some discussions on how academy will be managing, or the secretariat for the training, link it to this because you are going to link the training with whatever is already running, not start new, but optimize it by centralizing everything rather than getting the small hospitals to also do the teaching. Just link whatever is taught virtually.
Yes. So I think in terms of this project that we have, the sustainability of the project will depend on, of course, the local people, right? The local hospitals, the 6 hubs that are willing to put in the training as a training platform. The ECHO can be hosted by our ECHO. But I think we will really love to have the academy as a sustainable partner in terms of at least, when we talk about sustainability, we need to have a financial model. We need to sustain it with people. So we do have a, you don't think so?
No. Can I just suggest this? Because to be sustainable, even if you want to start with a coordinator now, yes, you can do it because you've got grant, right? But this is not going to be sustainable because not that we cannot afford to do this. It is a lot more from the expertise point of view. I mean, a coordinator to run your 2 monthly, it will not be cost effective, I would say. But what I would think that gather what is already currently running as MDTs, gather the information first, linked to whatever can be linked at a national level. Even your 6, you're not going to say that these are 6
because you see, the unfortunate thing is that breast cancer is the commonest cancer. The numbers are tremendous.
Yeah, but
so if you look at the numbers of MDTs we do a week in PPUM, we can do something like 30 diagnostic MDTs a week. And to actually bring in another spoke hospital to bring their cases would be almost impossible. That's why, to make it sustainable, we have 6 hub hospitals with all the experts, and they do it only once a year. So this is something that we hope that we can sustain, because even negotiating with the oncologist, I think Dr. Nina over there, we were thinking, okay, is it once a year or twice a year? If once a year, I will do it. If twice a year, sorry, difficult. The department does not want to do it. So this is all negotiations that we have done with the 6 hospitals. We've all agreed to host each MDT, that we will partner with our spoke hospitals.
I know, but and MDTs at 2 monthly level, it is not.
It's a training platform, Prof. It's not really.
So it's different.
Yes.
A training platform is different. You can do it more regularly. It's not what we actually have in mind. I thought you were talking about MDTs of trying to discuss cases.
We can't do that because the numbers are tremendous.
But what we actually wanted to say is that you do not discuss all, isn't it?
Yes,
you choose the ones that you want to discuss, and this is how I think it will be a lot easier, because there is also a need to actually have this platform for case discussion, not just the training.
Yes, so the training is based on cases that the spoke hospital will bring forward. And we have the 6 hospitals that have committed their experts to run the MDTs. So what we need is a platform where we will be able to have a secretariat. That means, secretariat means funded by our own efforts. That means we will be getting, hopefully, unrestricted educational grants from industry to sort of sustain this project
for 1 year, and then we'll see how we're going to move on to the second year in 2024. We do hope this is going to be sustainable in the long term, because the 6 hospitals have sort of committed, and it's only once a year. They only do it once a year. And we open this to other hub hospitals. There may be other hospitals that have all the specialties involved to be able to run another hub. So if let's say we have 12 hubs in 2024, then we can do the MDT once a month, because I think we have to figure out how to sustain it in terms of time, because we know time is actually the most precious commodity among the experts at the moment. Okay, so sorry, I'm going too much. I'm not the panelist. So shall I move on to Dato Professor Rahim? What do you think MSQH in terms of how do we sustain, in terms of maybe incorporating it into those standards, the ones that you are doing right now?
Well, the good news is that we already incorporated in the 6th edition on patient-centered care the standards with regard to multidisciplinary team, and we have the criteria. We are hoping to actually looking at actual ways to do it, which means this is something that I see as an opportunity for us as well to say that, why don't you start with breast cancer? Why don't you start with HICC or something like that? But this is under patient family rights standard. It's for patient rights. And that is one element in terms of patient-centered care, multidisciplinary team. Okay? And of course, in our HIMS standards, we definitely recommend integrated records and so forth. In this case, multidisciplinary teams require records that is integrated, and for you to actually share it with other experts. How do you do that? I saw one hospital which actually has got this clinical information system that's really focused on the patient, and they've got multidisciplinary sections on the patient in terms of, and the other specialists are able to access that and able to, at the end of the day, it's about informed decision making that you all have to do as a team, isn't it? And that is very crucial in terms of how do you get that integrated records to actually make those decisions, whether face to face or through virtual possibilities. The other thing that that is opportunistic is that the government and Ministry of Health is pro our accreditation program, and they are in the next 5-10 years are very focused on getting hospitals accredited to actually meet those standards in terms of having the multidisciplinary. In the 7th edition, we are hoping to actually focus on that part on patient-centered care, on continuity of care, care that is customized, tailored to the individuals or group of patients, in this case, breast cancer patient, for example. So we can actually recommend that to hospitals who are actually looking after breast cancer, for example. But this is not just meant for a particular discipline. It's generally basically for patient family right. But it is related to the other services in that sense, the other disciplines and so forth, including pathology and others. The other thing is the government is also pushing on that Center of Excellence guidelines to ensure we call higher quality care, better care at the highest level possible for, This is moving beyond just mere accreditation, right? And as you know, we are actually using breast cancer as a template for oncology, as the first example, and we hopefully to be able to do that in the next couple of years. And we hope, that plan that you have in terms of multidisciplinary is part of that standard that we want to incorporate. Yeah. So in terms of getting to the government indirectly is in there, but actually to get them to focus to give resources is another thing, right? And that require leadership. Nephrology, if Tan Sri Abu Bakar was not there, nephrology would not be expanding as it is now. From just everybody has to go to HKL 40 years ago. Now you can have your dialysis anywhere, even in the most rural of the districts and so forth. So it's about leadership as well, and that leadership has to come from the professionals, the clinicians, and the data. I can tell you, politicians are afraid of data. All right, you give them the data, the analysis, and so forth. They cannot say anything more. They cannot be populist of that. All right. The other thing, in regard to your medical excellence, accreditation don't actually look into your black box in a sense. That is your professional discretion, freedom. We don't actually go into your black box. That is where you all have to come up with. But the one we are focusing on is service excellence. One thing is timeliness, which is very important. During COVID crisis, I have feedbacks from patients and so forth. Having problem trying to get to see doctor for breast cancer and some other cancer and so forth, and some of them died. Because the preparedness and response is not really there in terms of that. There is some sort of lack or loss of integrity in that process because of that crisis, the COVID. I think it's happened to all the other disciplines as well.
Yes.
And I can say, places like UK, for example, timeliness is the responsibility of the politician, the government, not you all. Because the resources are related to that. All right? In our country, they push it to you, back to you, or back to administrators like me, to make sure that the waiting time is short, waiting list is short. But in UK, the politicians have to answer that. The minister has to answer that. The director general has to answer that. Where is the resources to ensure the time, the waiting list is shortened and so forth. All right, I think that is the thing that we need to push. I'm together in terms of that.
So rightly so, Prof.
Yeah.
I think what you mentioned about timeliness and the importance of that in quality care. So maybe we can shift a little bit to Dr. Rose, Suzanna, because I think as you say, rightfully, everything is then blamed onto the clinical service. So Dr. Rose, comments about this.
Okay, I try my best. Okay. So for Greater Petaling, there are 4 centres, public centres, 2 under Ministry of Health and 2 are the university hospitals providing the radiotherapy and oncology services. And there are also big hospitals that don't have the oncology service, but they have the breast surgeons. Well, actually, for these 4 centres, I will assure you that the MDT, the breast MDT, is frequently done every 2 weeks. But of course, we don't see all patients. We see, in average, 10 to 12 patients every 2 weeks. And most of them are locally advanced breast cancer, selected recurrent cancer, or also difficult cases, especially like breast cancer in pregnancy. So it is very frequently happening. And I think this is maybe the oldest MDT among all, tumor sites. The other issue, I think this is maybe in Malaysia, is the number of oncologists. We are struggling with the numbers. For the past 5 years, our numbers in the public sector has remained like between 30 to 40. So now we have actually improved like to 50. And of course, the sheer workload is tremendous. And I see that the efforts actually, in terms of the Ministry of Health have supported the CPG, clinical practice guidelines, and these MDTs is going on. And I think your suggestion, Prof. Aishah, is more to training, right? It's every 2 months, echo, MDT echo, I would say.
It's for the
so therefore we can actually select, some of the interesting cases and discuss. But I don't think it's a proper MDT because we have been doing
it's not
MDT.
a proper MDT, but because we wanted to involve the single specialist hospitals, because the majority of breast cancer is managed by them. Actually, most of the patients are managed by general surgeons, unfortunately. So we need to bring them into the fold, because right now you will have the perfect enhanced care in the breast surgeon hospitals, but in the general surgical led hospitals, they really have no access to breast radiologists, oncologists. So they may actually be practicing, we don't know at what level. So this is the people we want to bring into this network of MDTs.
Okay. And actually, like we do receive requests for several other MDTs. Like Prof. Rose actually approached me for the liver MDTs. I think at least we have more than 10 MDTs.
Okay.
Ongoing. So quite
quite tight, right?
Quite tight. Very tight. So therefore, that time is a very limiting factor.
Yes.
So, but hopefully, maybe in the future we have more oncologists. We're hopeful to have medical oncologists on board as well, so that maybe
so this plan of ours is like one hospital once a year. So hopefully there is buy-in from the experts to actually run this inter-hospital MDT platform. Okay, so I think careful. Okay. Maybe we just continue to Dr. Izuna, because I think we also know that this is a document. And documents will be left as documents and never used. So maybe, Dr. Izuna, what would you suggest we do to make sure that this document is being used and utilized?
Thank you, Prof. Aishah, and hi everyone. Okay, thank you for all the comments from the experts. I would like to explain a bit in terms of the CPG implementation, monitoring, and also evaluation first. Okay, so in terms of implementation, maybe yesterday I have mentioned a bit that the evidence-based clinical practice guidelines is the national CPG and is being approved by the Ministry of Health. It is chaired by the Director General of Health, and we have representatives from various sectors, including the universities as well as the private sectors in that council. Okay, in terms of implementation, so we disseminate all the clinical practice guidelines to all the facilities. So we also produce the 8 pages. We call it as quick reference for easy reference for our healthcare providers. And we also develop the training modules that we use to train the core trainers. These are the experts that we from every state in Malaysia, so that when after the training they can go back and train the people in that states. So we provide all the modules that have been developed by the guidelines development group as well. So other than that, we also launched this clinical practice guidelines so that everybody know that there's a guidelines to manage this disease. Okay, and we produce infographics in the social media as well, so that it is widely spread too. Okay. Other than that, in each clinical practice guidelines, we also have clinical indicators. Okay, and these clinical indicators is linked with the clinical performance indicators, which is monitored by the Ministry of Health for each clinical discipline. So we have that. So data is collected from the hospitals and actually analyzed at the central level. So we do have that as well. But I don't think this MDT is part of the key performance indicator yet. It's not yet. It's not yet, because we are starting, and of course MDT is one of the recommendation in the clinical practice guidelines of the 3rd edition. Okay, and Ministry fully support the effort, and I think to make sure that this MDT effort is successful, we need commitment from the clinicians, from the professionals, all the multi-stakeholders involved. And these stakeholders actually are part of the, in clinical practice guidelines development, we have development group, we have review committee. So the review committee are the senior consultants or the head of the services usually, which comes from not only Ministry of Health, they also will come from the either private sector or also the academic side from the universities as well. So in terms of I love to hear from Ms. Ranjit just now that actually in terms of patients' view, MDT is something that they also feels that is important. It brings more confidence to the patients as well. So maybe further promotion, but we must. I know MDT is already there in the bigger hospitals here, so we can also let's say like promote further and also to inform patients so that they have more confidence in terms of the management, their management in breast cancer, so that they know how the decisions are made. It's not only made by one doctor. I have not thought about it. That patients actually worried in terms of who made the decisions actually. So it's nice thing that maybe this can be something that we can promote further to improve patients' confidence and also so that they come earlier for treatment. I think in Malaysia the issue is that diagnosis is made quite late. They come quite late for treatment. That is the issue.
I think before Ranjit comments on anything, if you relate back to the document, how do you think this document will fit into the dissemination and implementation of the CPG?
Yes, of course, this document actually elaborate further. In the clinical practice guidelines, there's just like a paragraph on MDT, and this document actually elaborate how you can conduct the MDT in your hospitals, for example. So it's actually facilitate the MDT implementations in the hospitals.
Can it be used as one of the tools that you already have state champions that will be training the CPG content in all the states? Could this document be like a supplementary document to that training?
Okay, one thing is that the training of core trainers has been conducted is ongoing. At the national level is already there, but I think in the state level it is ongoing. Okay, so we can actually inform the clinicians or that we have come up with these tools or a new document to help them implement this MDT. Okay, I think this is something that will be useful for them. It will be one of the implementation tools. Okay, and other than that, I have not mentioned about monitoring as well. So when we distribute the clinical practice guidelines, we also monitor whether the training of core trainers being conducted at the state level. So we will get the information from the states as well. And also from time to time, sometimes we do conduct study on the adherence to the clinical practice guidelines. I think since COVID-19, since the past few years, we have not conducted any adherence study. Some that have been planned, so we have put to postpone or we cancel it because of the pandemic, that we need to concentrate the resources to for the COVID-19 management actually.
Okay,
so
thank you.
That are some of the things that we do to ensure that this clinical practice guidelines is being implemented at the ground level.
Okay, thank you, Dr. Zura. I think that was a very clear, information about how CPG is being trained all over the country. So, of course, we'll let you have the last word. I almost called you Dr. Ranjit, okay? Ranjit. So, we'll let you have the last word before we open to the floor for a bit of discussion.
I just want to congratulate the team for having done the 3rd edition of the CPG. I was invited for the 2nd edition as a patient representative. So I do hope if I'm still alive, when you do the 4th one, you can invite me. Thank you.
Okay, was that your last words? Yeah, okay. All right. So I think we've ended the panel really, but we open to discussion right now before we finish in about 5 minutes. So any questions from the floor or comments from the speakers or panelists, please just jump in.
Yes, I will be the care physician. I know that many people think that our patients is quite scarce, but we are not, we are rich. So basically, palliative care is available in almost all states, apart from Sudan and Kelantan. So please do feel free, we are approachable. So if you need us in MDT, I'm pretty sure that can be arranged. Majority of us are quite happy.
Okay, thank you. That was like a commitment from the palliative care physicians. Thank you so much. Yes.
Hello, I'm Zahrin from a radiologist from ICAN, Institute Cancer Negara. Could you add in nuclear medicine as a physician, as one of the, the team, because we have them on our team.
Okay.
So I takut nanti kecil hati pula diorang.
Okay, alright. Thank you for that comment. Okay, anyone, any comments or any more additions? I think Dr. Rima over there. Somebody got to send her the mic.
So it's a good time for y'all to just roll back and see what is the commitment towards data collection. While you are starting out the MDTs, and like he rightly mentioned, politicians are afraid of data. So have you factored in how you are going to be collecting all the data on all these patients' treatments and outcomes? Because it forms an integral part of trying to achieve something. Because you have to always receive feedback that whatever you've been doing, is this the right approach? Has it helped in any way? So apart from these policymakers looking at certain indicators, are you also looking at collating and collecting nationwide or group-wide data, since you are rolling out a special program like this for breast cancer?
Okay, I think Rolando was...
The same question, so you can include that in there. Because I see, I've been commenting about the indicators. This is the information that they have to collect to measure the indicator. And always I have been advising Aishah to be careful in the number of indicators. So large number of indicators means poor collection of indicators. And it's a blockade for authorization of including the indicator in the regular, because it's a smart also position not to authorize very large list. So it's important to focus which one is really important for this, but identify the rest, because the rest should be, and the academia in this case will have a role in this, should be used for research. Sometimes people do not find what to do for research. The thesis for whatever, or these are a great opportunity because there is a number of indicators that you cannot use as a routine, but you can use as for providing data that is needed for taking decision also.
Yeah.
If I can just add a little bit with regards to implementation, I think that's one of those aspects that most of us are most concerned about. We hope that this 3-day event will translate to a difference for patients. So coming from a clinical aspect, I think, in my personal opinion, making it mandatory might be something that we may need to consider. Because frankly, as much as the CPGs and the documents are recommending a lot of things, I really don't see it happening unless it is somewhat made mandatory in a way that we engage with perhaps from the ministry for government side, from the ministry side through the respective head of services to engage people in respective centers to be committed, maybe out of a voluntary basis if they are keen, but if they are not that coming forward to volunteer, perhaps assigning people, because sometimes I feel otherwise we will not get anywhere with this, because frankly, a very simple thing like doing ER, PR on initial biopsy specimens, we struggled for years to get that happen, and it was only until late last year that we got it through. After initially clinicians were calling respective hospital pathologists, asking them to please do ER, PR on initial biopsy, but it never happened. It only happened after we engaged through the National Head of Pathology Services, who issued an official directive, and it went down to all the Ministry of Health hospitals, and now it's happened. So somehow I think when it's at a level of the respective hospitals, we somehow don't see it happening very easily. So my personal opinion and suggestion is, for Greater Petaling, government side, of course, the 4 main hospitals which have oncology, radiation, I think that's no big issues there. The next level is the hospitals with multiple specialists who are doing breast surgeries like Sungai Buloh, Selayang, Ampang, Klang, Shalam. I may have missed out 1 or 2. But these are big hospitals which do a lot of breast surgeries. They have multiple specialists over there. So Selayang, we have started MDTs now. But trying to get maybe 1 breast surgeon, 1 oncologist, 1 palliative person, 1 breast care nurse, 1 radiologist to be somewhat in charge of these centers and to have a deadline to say, okay, by this date, MDTs have to run. It has to happen. So if it comes as a directive, perhaps from ministry, I think it will really happen. I mean, since now there's some MOU with the ministry, and I believe that is the only way this is going to happen, because at the clinical level, most of us have tried, and we are actually a little bit tired as well because it doesn't seem to move. The reason of short of staff, short of time, short of all that has been going on for a long time. And frankly, in the Ministry of Health Services, most clinicians leave to private practice extremely fast. So although we are training and churning out specialists, we don't retain them in any way. So if the ministry could look at ways to keep the specialists in service, that might be something that would translate to a difference in the long run. So that's the staffing. Next thing is bahagian perkembangan. I know that both of you are not from those bahagians, but in terms of waiting time for diagnosis, right, the main limitation is actually CT scans and bone scans. So the majority of breast cancer patients, even in HKL, get staging scans 6 weeks post-surgery. We don't have scans at diagnosis, and that's the premier hospital of the country. It's not that I want to highlight negative things, but I think it's something that we need to do something about. So these issues were already brought up to our minister. I know politicians and issues, but I think our current minister is very open to hearing that everybody is complaining to him directly. Everybody just goes up to him straight. And I think it has translated to a difference. So they've approved for buying of services with private. So HKL now has got, just in the last 1 month, outsourcing. So just trying to cut down waiting time so that at least our patients have diagnostic scans before they go for surgery. Because if we don't even have scans, we can't do an MDT.
Exactly.
Yes.
So thank you for all that comments. Everything, this is the final bit of the thing, is how do we get the data? And this is so important. So I'm looking at Dato Rahim because, you know, when you have accreditation for hospitals, data needs to be collected. By hook or by crook, the data is collected. And there is a department that collects the data. Of course, Dr. Rose will say, no, in the end, the doctors will have to collect. But the quality department, isn't it, Dr. Rose? Every hospital, we have quality departments. So, for example, in TPUM, we used to have a problem with surgical site infections. And then we just put it as one of the indicator. And now our infection control team actually collects data. And it's regular, it's routine. So we want to do something like that for timeliness in diagnosis, timeliness in treatments. And maybe because you mentioned about staging investigation, that could be also one of the, mandatory type of data that we would want to put in standards, because this is going to translate to quality care. So in the document, we have a lot of indicators. We have actually put there optional indicators. That means the more detailed, like MRI within 24 hours of spinal cord compression. That one I think is a bit too much. But it can be something that a hospital may want to do, right? But there should be essential, mandatory data points that we need to collect. And we really hope that MSQH could be our partner in ensuring that these data points can be put into the standards. And if we can put, in the 6th edition, which is the current one, we would be very happy, so that the quality departments would be able to act upon it. Because I think once we know exactly what data we need to collect, the hospital, the administrators can do it, because timeliness data, you don't need a clinician. You just need a definition of what data needs to be collected, and that's it. The administrator can collect the data. And we can keep track of all the timeliness within each hospital, and we can track the country also, because it is part of the quality department data collection exercise. So what do you think, Dato? Inshallah. Okay. So any more comments, or else we are now at 12:16. There's a comment? You all shouldn't feel excluded,
We are very included. Yeah. HKL team has been very, very loving to us, literally, not sarcasm. Yeah. Knowing lunch is there, I've been looking at the lunch also. Yeah. So I'll make this quick. So sometimes palliative people think that we only see end of life. So, especially when COVID happened in HKL last year, everyone looked at us like we are some angel of death. Every time we walk in, people say, "Oh, patient is going to die. They're going to start morphine." I'm like, no. More than half of our patients come to our clinic. What we try to do is help them to live a little bit better, where they sleep better. If they can smile, that is, of course, and always a happy outcome. Yeah. So that is our aim. So, because this is a MDT and there's so many people here who are non-palliative, we are so happy to tell you that refer early. Although when I say this, I know my colleagues will want to line up and slap me already, because we did 3 awareness workshops this year and the referrals are piling up. But refer early. The palliative care, when people hear the term palliative care, people take a step back. So we tried other names such as supportive care. It had a bad outcome because people think we are non-clinical people. We are here to support them like a volunteer. So it really defeats the purposes. So it's really awareness of people understanding what palliative care truly is. There was a landmark paper in 2010 done by Tamel. So what she actually did was, and their team was that they actually took every single patient that was diagnosed with stage 4 lung cancer. And it actually, interestingly, prolonged survival by 3 months. So that was a very big landmarks paper. Unfortunately, no one did it for other diseases. So something to consider is that palliative do help. Even if they don't live longer, they live better. Thank you.
Thank you so much for that comment. I think we don't routinely refer early, So I think we should refer routine at least stage 4 cancers, right? At least it's not that many. I mean, it's quite a lot, but it's not that many as compared to everyone, right? So we can actually select patients to refer early to the palliative care team.
Detect patients, because if we are going to take every single stage 4 cancer, in Malay we will pengsan, we will faint. Yeah, we really cannot cope because, for example, in HKL, the palliative physicians double role as a general physician. So we have general medical wards to take care. So that is really a large part of our time also. So hence, using this distress thermometer, detecting whether they have distress or not, and then if possible, try to do simple management first. The ones that the distress goes down, don't need to get referred, but the ones that are still having distress, do refer.
Yeah.
Thank you.
I think this is a great idea. And from what the comments that we got from the faculty about making sure that at least we know what to collect, the information from the patients to present at the MDT in terms of a pain score maybe, distress thermometer scale, the synoptic nursing psychosocial checklist. So this could actually be incorporated as an appendix to this document to say that these are the important points that should be brought forward in the MDT. And then from that, I think it makes our life easier also during the MDT to know these factors. Because most of the time we don't know about the patient. We only know about the disease, the images, the biopsy. So I think by having this would actually strengthen and make the MDT also a bit more efficient in terms of time. Because what will happen is after we make that treatment decision, okay, we have to talk to the patient and find out about all these other things. And if we did it before, and maybe by having the synoptic forms, the MOs, we can actually get them to fill them up, or the nurses, and then doing MDTs will be much more easier. I think that's a wonderful addition to the document if we have to. Yeah. Okay, Ranjit. Okay.
Coming back to MDT, one of the things that I've always tried to, grapple with is, why is it that in Malaysia we don't have a career path for nurses up the particular sections, like if it is palliative care all the way up, breast cancer, breast care nurses and things like that. I think that is needed in this country, so that they can go up rather than being transferred from one department to another, because they specialize in one department and then they are referred, they get transferred because their salaries have to be increased, or their position or whatever grade it's called. So that's one. I think, just coming back to palliative care, I think it's become a very popular topic right now. I think what I was trying to say was that from the patient's perspective, the day that we are told that we need palliative care is on the day that that particular physician, their body language is, you're going to go soon, so now I need you to go to the palliative care doctor. So that's the problem that we as patients are facing. If right at the very beginning, when we are diagnosed, we have a palliative care, we have a nurse who is giving us palliative care, a nurse who is trained and she can give us, we know that that intervention is already there upon the time that we are diagnosed. And in that way, it is easier for us to be able to be part of this whole process. One of the problems we face is doctors themselves have this attitude towards palliative care. Okay, it's a negative attitude. It's their negative attitude that transfers to us. We didn't get that attitude from outside. We got it from the doctors. That's what I'm talking about. So you doctors need to train your people not to be negative towards palliative care.
Okay, thank you, Ranjit. Ranjit has always put our doctors, in line and following the right thing, right? Okay.
20 years ago, Tan Sri Abu Bakar, yes, and Tan Sri Ismail, we came up with a strategy to actually professionalize nurses, and also the other allied health professionals. So you can see the legislation being developed and coming up, and in the last 20 years, actually, we're actually encouraging the nurses to actually explore their frontier of the body of knowledge that they have, not to be dependent on the doctors anymore. But professionalization takes a long time. The doctors took a long time. But we hope, learning from the doctors, the nurses will be able to do that faster. In our country, the law still say the doctor can admit, can discharge, and can order and so forth, but not the other. Right? But we have stopped calling nurses paramedic. We have stopped calling nurses semi-pro. They are outright professionals now. So we are moving there, and we hope some leadership, particularly from our doctors as well, not just from the nursing, actually push this faster. Because to me, our medical knowledge has expanded so much. I don't think the doctors alone can actually tackle that body of knowledge. I think they have to pass it to people, like nurses, in terms of that, and explore that frontier, whatever it is that may be in front of them.
Yeah, I think rightfully said. I think the nurse is part of the team, and the nurse is the professional in the team. So I think the breast team probably have a very good understanding of that, because without the breast care nurses, we can't do a lot of things. So with that note, that multidisciplinary input is not just about doctors, it's also about nurses, and how we can move together, and people can play different roles with different skill sets so that we can actually achieve something better. So on that note, I think we've had a good discussion. Would you all agree that we had a nice discussion today? We've had a good feedback about the document, and I think we can improve on the document. And in terms of the resolution from this discussion, we've got our main stakeholders here from Academy of Medicine, from MSQH, from Ministry of Health. It looks like we are quite ready to try to improve the MDT best practice in Malaysia. And even though we are starting here in Greater Petaling, the ripples, because when we perform it virtually, it will be open nationwide. So with that, I think we will have to end the panel discussion now. And thank you very much to all the panelists and for all the participation from the faculty, from the participants today. And we hope that tomorrow, when we go back to work, tomorrow is Monday, right? Yeah. We will start thinking about implementing MDTs if we haven't done it yet. Okay, with that, thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Thank you.